Good afternoon, everyone, and welcome to this webinar, which has been designed as an interactive session, which is based on a fictional case scenario to help us to think about mental and physical effects of COVID-19. This session mirrors a series of similar scenario-based webinars, which we have run and been presented by our higher trainees at East London NHS Foundation Trust during the period of March to June of this year. And it's around assessing and managing COVID-related cases in psychiatry. All of the materials from these sessions are freely available, and the link is included in today's slides. So I'm very pleased to say that the session has been written, researched, and will be presented by psychiatry trainees from East London Foundation Trust. And they are Dr Cate Bailey, a higher trainee in general adult and old age psychiatry, MHR UK scholar for an MD on functional neurological disorders, and the trainee editor at BJ-Psych Bulletin. Also, Dr Jia Song, who is a core trainee at Elft. She has a BSc in psychology and an MSc in clinical neuroscience. She's also a contributor to the BMJ's weekly blog on neurology and neuropsychiatry of COVID-19. Then we have Dr. Lynsey McAlpine, who is a higher trainee in general adult psychiatry and an honorary lecturer at Barts in London. And Lynsey has a special interest in perinatal mental health and medical education. And finally, we have Dr. Fawziya, who is a ST6 dual trainee in general adult and old age psychiatry. And she has a real passion for liaison psychiatry and medical education. And she is particularly interested in mental health and social issues affecting our BAME communities. And in her spare time, Fawziya volunteers with organizations addressing these problems. So the materials that we've been using today have been expert reviewed by service users from East London Foundation Trust People Participation, Upma Monga and Mac McLean, and by very generous clinicians from UCL, from Glasgow and Tavistock, as well as our colleagues at Elft. So we are really grateful to all of these individuals for supporting our trainees to present this case, which draws on a number of impact of COVID-19 on our communities and on the subjects of trauma-informed care, racism, and health, amongst other themes. So whilst all of our NHS staff have been focused on the acute management of the crisis, we have, of course, also been looking after the impact of COVID-19 in the longer term thinking about where most of the impact has been felt. So this is what the case is about, and our presenters will, at times throughout the hour, ask questions of you as the audience. So please listen out, and we would really appreciate your comments and participation. Comments in the chat box, please. So when they ask you questions, please make comments in the chat box. But if you have questions that you would like to have answered, you could pose them towards the end of the presentation, and we will try and answer them and give ourselves a bit of time to do that. So comments in the chat box, questions in the Q&A section, so we can keep them a bit separate and we know what we're doing. So I hope that's clear. I hope you enjoyed the session, and I'll hand over to my colleagues.
Hello everyone, thank you very much for the introduction, Navina, and welcome to our webinar. Thank you all for being here. We invite you all today to join us together and discussing a fictional case that relates to the management of mental and physical sequelae of COVID-19. Before we start, we'd just like to highlight that the case will touch on topics such as racism and trauma, which we understand may be distressing for some people. Next slide. Next. So imagine you're the SHO, psychiatric SHO on call over the weekend, and it's 4 AM at night. You receive a call from the medical SHO. He sounds very stressed and he asks you to see a patient urgently. he thinks the patient may need sectioned because they're demanding to leave the ward and they seem psychotic to him. And they're saying things like they think the nurses are trying to kill them. Next slide. He tells you that the patient has refused all of her vital ops to be done, and she's also refused the offer of lorazepam. He can't really assess her capacity because she's also refusing to speak to him, and he doesn't really have time to spend time with her anymore because he's got somebody else very sick to attend to. So he's asked you to kindly come and see her quickly.
So what is your approach here? Use the chat function on the side to let us know what you would do in this situation. So it sounds like some people think that we need some more information about this patient, which I think is absolutely fair, and some suggestions here about where we could get some more information. So some people are suggesting we try and get into her medical records and look at her background history. Some good suggestions about clarifying a bit with the medical SHO. What do they mean when they say that she's psychotic? And you want more of a clear description from the staff of why they think that she's psychotic. Yep, a lot of people saying that they would be very keen to go and see this patient as quickly as possible. And yeah, I think it seems the consensus is that you would be going to see this patient pretty quickly, although you would be trying to get some contextual information about the patient before you go along. So these are the things that we thought about. We thought certainly we'd want to review her notes and look at her recent reviews. We're quite interested to know what the current medical issues actually are, and what is it that is keeping her in hospital at this point? Does she really need to be here? Another point we thought of, which is popping up in the chat here, some of you are suggesting finding out about friends and family that might be able to offer some support, which I think is a really, really good approach. And certainly we want to think about her capacity as well, and whether there are any factors that might be affecting her capacity to make decisions about staying in hospital. Certainly from the very brief bit of information we've got, we could be thinking about hypoxia, about delirium, about depression, anxiety. There's a lot of different things that we need to be exploring here. Certainly the front of my mind going into this, assess this patient, is the question of what the risks are here, and also what we really want to know is what is going on.
Okay. So before you go and see the patient, you decide to just read through her medical notes first. So you see this is Miss T, and she presented to A&E 2 days ago via ambulance with shortness of breath. When she first presented at A&E, she was found to be tearful and anxious and was described as a poor historian in the A&E notes. You actually find out that she was recently discharged from the hospital, having been admitted with COVID-19, and during which time she's required a period of ITU admission. And she has multiple medical histories that gives her increased risk of cardiovascular risk factors. Next slide, please. You also try and look up to see whether she's got any past psychiatric history. You see that she's never been presented to the local secondary mental health service, but there is a diagnosis of depression dating back to the 1990s in her GP record. She lives alone and works as a teacher, but is currently on sick leave. And you note that the medical note said that she has no official next of kin, and that when she is ill and currently she has to ask a friend to look after the dog during this period. From her last mission, she was discharged with a one-day package of care and had volunteers coming in to help her with various other activities. Next. You read up a little bit more about her last mission with COVID. You see that she was admitted for almost a month. This included 5 days spent on ITU. It's documented in the ITU notes that she suffered delirium whilst on ITU and was paranoid and agitated, which meant that she was given IV haloperidol and midazolam 3 times during her mission. It looks like that since discharge, Miss T had been struggling with fatigue and low mood. Next, please. So on this mission, Miss T was diagnosed with PE, having undergone a CTPA. You note that when she went for the CTPA, she needed a lorazepam because she was so anxious and scared. slide, please. So you see there's a plan from the ward round this morning that the medical team had planned to review her patch of care with the aim for discharge after the weekend. There's also a documentation in the notes that said that her friend had called the ward and had expressed worry about Miss T's mental health. Next slide, please. So you decide to go and see Miss T after reading these notes, as we have earlier discussed. You arrive on the ward and you see the medical ward is really busy and lots of things are happening because there's an emergency. So there's lots of noises and people are rushing in and out. Miss T looked frightened and wary. You got the nurse in charge to help you find someone quiet to see her. Although Miss T was reluctant, she did come with you. In the meantime, the nurse managed to get a set of ops, which is on the slide for you to look at. Next slide, please. The first thing you do is ask how Miss T's feeling, and she looks stunned when you ask her this. You tell her that you imagine she must be very frightened to be back in the hospital again, given everything that's happened, and you manage to develop some rapport. So after a while, Miss T starts to talk to you. She tells you that when the crash team came, she thought they were coming for her. She also tells you that in her last mission, she doesn't remember very much of her time on ITU, but she does remember seeing knives coming at her and having the feeling she was choking and falling. She remembered believing the nurses were trying to kill her at the time, but she was too scared to tell anybody and had just hoped to be allowed to leave the hospital. Next slide, please. But since her discharge, Miss T said she continued to see these images of knives coming at her whenever she closed her eyes. She also struggled to get to sleep, and whenever she is asleep, she's having nightmares. She tells you that she has panic attacks almost daily, and she can't escape being reminded of COVID as it's always on the news. She tells you that she feels exhausted and disconnected all the time, and she doesn't remember anything and feels that her mind is broken.
So at this point, what else would you like to ask? What questions would you be asking Miss T? So some suggestions coming in about exploring symptoms of PTSD and questions about delirium as well. People are specifying some of the particular things about PTSD they'd be looking at, so flashbacks, avoidance, whether she's being easily startled, and some other questions coming in around her disorientation as well. Any other suggestions? Yeah, so we would certainly want to be asking about her mood, whether there's any core depressive symptoms there, and whether she's having any thoughts about harming herself. And one or two people have come in with a very good suggestion, which is to ask her about past traumas. Now that's something that's going to be quite hard to ask in such, acute, frightening situation and could potentially re-traumatize someone. But it's certainly something that we'd have at the back of our minds when we're thinking about this lady's presentation. So here are some of the things that we thought of, and you've suggested most of these already. One question that I really like to ask and that can be really valuable here is just to ask her what it was like when she was in hospital before. How did she actually experience it? I think that question can be really, really illuminating in terms of understanding what someone's been through. As many of you suggested, we'd also want to ask about mood, about delusions and flashbacks, and whether she's having any other symptoms of re-experiencing the trauma of being in ITU. We'd also want to know about any dissociative symptoms and any suicidality. We'd want to know what coping strategies she had been using before coming into hospital. And as always, we'd want to know her psychiatric history, her personal history, and everything else about her background.
So you continue with your history taking with Miss T, and you manage to get some more information from her. Miss T tells you that she feels cut off sometimes, and the other times she feels guilty. She thinks that she should be grateful that she survived COVID-19, but she feels broken. She also feels that it's her fault that she got sick because she had read about how obesity and diabetes are risk factors for the worst outcome of COVID. Miss T tells you that she used to drink heavily, but have been abstinent for 20 years. She said that when she was a teenager, she has self-harmed by cutting a few times because something bad was happening in the home environment, but she didn't really want to go into that at the time you were seeing her. She did take an overdose at the age of 28 after leaving an abusive marriage and suffered a miscarriage. She got psychotherapy from a charity and found it really helpful, and she's not had any contact with mental health service. She lives alone and doesn't have any romantic relationship, and she's really scared what she will do if she never gets to work again. Next slide, please. So on your examination of Miss T's mental state, you note that she's really tearful, hypervigilant, and easily startled. Her speech was normal in tone, speed, and volume, but occasionally she had word-finding difficulties. Miss T says to you that she feels low in mood and she has poor sleep, and objectively she looked anxious. There was no evidence of any psychotic symptoms you could find. She had no formal thought disorder or delusional belief, and she tells you that she doesn't really believe the nurses were trying to kill her. Although she feels that her life is not worth living and wishes she could fall asleep and never wake up, she denies any specific suicidal ideation or intent. She reports these images coming at her of knives when she closes her eyes, but when you explore it further, you found there's no evidence of any auditory or visual hallucination. Miss T tells you that she struggles with her attention and concentration, but she is orientated to time, place, and person and is not confused. She's aware that her mind is playing tricks on her and she feels little hope for the future. Next, please.
So at this point, what is your formulation about this patient? I think from our point of view, what we're seeing is this 58-year-old lady who's got this history of a possible early life trauma. We know that she's a survivor of intimate partner violence and pregnancy loss, and she's experienced a really severe critical illness in the recent past, which was associated with delirium. She's now back in hospital and is finding the hospital environment terrifying and re-traumatizing. So there is a lot to think about here. You've certainly been coming up with a lot of suggestions about what could be going on. A lot of people talking about PTSD plus or minus psychosis. Quite a few suggestions around depressive disorder as well, or anxiety disorder. And of course, in this sort of setting, we'd always be thinking about adjustment disorders, delirium, and psychosis as well. I think one of the key things that's coming up here is we're very aware of this very traumatic experience that she's had quite recently, and so I suppose we're wondering about the impact of her recent ITU admission on her current mental health and her current presentation.
So I think one of the things that we were aware of even before COVID was that certainly people who've experienced critical illness aren't necessarily out of the woods just because they've kind of left ITU or even left hospital, and that there are kind of ongoing cognitive impairments, physical impairments in terms of lethargy, sexual dysfunction, chronic pain, and also mental health impairments, so PTSD. And Dorothy Wade and her colleagues at UCL have done a systematic review, again pre-COVID, and found that kind of up to 27%, almost a third of people who survive an ITU admission experience PTSD, and about 31% of people can have depression. Next slide, please. And when we think about the things that might be risk factors, as with other types of PTSD, things like prior trauma, lack of social support, and kind of support after the trauma, history of mental health problems, younger age and female gender are risk factors. But when we think specifically about the ITU experience, it's a little bit different because there's particularly delusional memories of ITU, so related to a delirium within the ITU setting. There's use of sedation as a risk factor, but that's obviously a complex one because people who are actually much more agitated with their delirium are more likely to get sedation and kind of chemical restraint. Mechanical ventilation and acute respiratory distress is a risk factor, as is awake paralysis for the reasons that you can kind of imagine, because of that sense of kind of loss of control and being restrained. Communication problems are kind of inherent to the ITU experience, and normal human kind of needs can often be very difficult to communicate. The ITU environment is of course kind of brightly lit, although things are hopefully changing, very noisy, not necessarily feeling particularly therapeutic. And then of course their experiences of very traumatic events in ITU. So being told that you need kind of critical care or needing intubation, having invasive procedures, watching other people die or being aware of that. Next slide, please. And again, Dorothy Wade and her colleagues have looked at kind of what the phenomenology of ITU or post-ITU PTSD is. And interestingly, it really tends to be a kind of merging of delirium experiences with real life invasive procedures. So some quite bizarre but awful experiences that people recount, which merge kind of catheters and intubation and things with kind of torture, with kind of really horrible experiences, and recalling hallucinations and delusions. Things can also be, of course, re-experienced in the body, so pain and shortness of breath. We know from Van der Kolk's work that, of course, we do hold trauma in our bodies. And the triggers for kind of re-experiencing these things will be things like the hospital or disinfectant, you know, scents, beeping, the colour of sterile gloves and PPE and that sort of thing. Next slide. I suppose one of the things that we've been much more aware of during COVID is that people have been talking a lot more about experiences of delirium. Perhaps that's because young people have been experiencing delirium more so. So there's some really vivid and kind of horrific descriptions of the kind of mixtures of delirium that people have experienced in ITU. Next slide, please. So when we think about what is it about COVID that also might increase the risk of post-ITU or post-critical illness PTSD? So again, we've got really high rates of delirium. We know that COVID directly kind of has brain effects. There's very severe inflammation. There's all of the communication difficulties related to PPE and staff shortages that might have previously kind of mitigated this in some way. We've been hearing from our ITU colleagues that there are very high rates of agitation and confusion, and perhaps even higher than a normal ITU population, and that there's a need to sometimes use more psychotropic medication or higher doses than normal. Next slide, please. We've got high rates of mechanical ventilation by virtue of the kind of COVID effects on the lung and respiratory system. There's also the potential that people are witnessing the death of others on medical wards more than they would normally, just because of the number and the sheer kind of number of critically ill people. The other thing is that actually looking at how COVID is managed, if you kind of observe someone being proned, it almost looks like they're actually already dead. So if you're kind of in a delirious state and you're looking to your left and your right and you're seeing people on their fronts, it can be very distressing. And of course, as we've seen with COVID, is that actually kind of the cumulative interacting risks. So the people who were already vulnerable to PTSD are the ones who are getting more severe COVID because of kind of adverse childhood experiences leading to adult disease, and the interaction with ethnicity, previous trauma and racism experiences, more severe illness. So it's a kind of perfect storm. Next slide, please.
So we're back with Miss T now. So we've got a 58-year-old single woman who's been admitted with a PE and a DVT following her recent experiences of critical illness secondary to COVID-19, complicated, as we've mentioned, by delirium and by her ITU stay. We've got a lot of phenomenology here. We know she's re-experiencing aspects of her delirium. She's having intrusive thoughts, nightmares, hypervigilance, panic attacks, mood that's fluctuating very rapidly between feeling very anxious and very numb, some passive suicidal thoughts. And we can tell that she's struggling in the hospital environment with many things triggering these symptoms. We also know about her history of depression and anxiety. There's a suggestion of trauma in her early years, and she's a survivor, as we've mentioned, of intimate partner violence. So how can we help Miss T right now? So right from the outset, a lot of people are saying that we should be trying to reassure her as much as possible, doing everything we can to facilitate communication, and thinking about what kind of psychological input we can offer straight away. There's some suggestions around starting an SSRI, and some more pragmatic suggestions around perhaps things like a side room to try and reduce some of the traumatic triggers that she's experiencing. Again, questions coming up about what support she's got in place at home. Are there any relatives or friends we could get involved in her care? And let's see, what else are people saying? Yeah, lots more suggestions around reducing her sensory stimulation, which could probably help with some of the symptoms she's experiencing.
So you're glad to see that after speaking with you and after your reassurance that Ms. T tells you that she feels a bit calmer now, and she does understand that it's probably in her best interest to stay in hospital until she gets the help she needs. So she's willing to stay. She tells you that she's absolutely exhausted and just wants to have some sleep. So you discuss with the medical SHO and think about giving her something to help her with her sleep. And you also think about getting her maybe an earplug or side room to help reduce the sensory stimulation. You make a plan also with the liaison team for her to be reviewed by the team psychologist after the weekend, and for her to be reviewed again by the liaison psychiatry nurse over the weekend. Next slide, please. So over the rest of your on-call shift, you don't hear anything else about Miss T, and you see that she's being seen by the psych liaison nurse, and she's doing okay, but she's still struggling to sleep. Next slide, please. So you're back at work now after your on-call shift, and Miss T is still on your mind. So you check Miss T's notes the following week, and just to see how she's getting on. You see that she's being seen by the liaison psychologist and psychiatrist, and more of Miss T's past experience have come to light during these reviews. She's recounted to the psychiatrist that in her first mission with COVID, her initial symptom of breathlessness was not taken seriously, and it was dismissed as anxiety. So she was later found collapsed in a car park before she was brought back and given oxygen and given more investigation. Miss T tells the psychiatrist that she's the only child, and her parents originally came from Barbados, but both have been deceased. She recalled growing up seeing her father always drinking and sometimes shouting, and she tells the psychiatrist that she had experienced racial bullying throughout her school years. Next slide, please. Throughout the week, you see through the notes that she also disclosed to the liaison psychologist that when she was 16, she was raped by her father's friend. But when she told this to her family, she was not believed. The psychiatrist and liaison team have started her on some sertraline and permethazine to help her with low mood and sleep. And the psychologist had started a discussion with her about getting some psychological therapy, which Miss T is willing to consider, as she found the psychological therapy she had in her 20s had been helpful. So a plan is made by the medical team and psychiatry team for Miss T to be discharged, and for her package of care to be increased to twice daily, with additional help from volunteers with cleaning and shopping. Next slide, please.
So thinking about the kind of interaction between trauma and COVID and the effect of kind of early life trauma being reactivated by the pandemic, Jo Stubley has written really eloquently about this on a Tavistock blog and also in her previous RCPsych webinar, and describes really well the central paradox of the pandemic, in that when we're under threat, we're kind of neurobiologically as humans primed to find safety and attachments, but in order to survive, we have to distance ourselves and do the opposite. And that the pandemic itself actually mirrors a traumatic experience. It has an inescapable nature, it makes us feel helpless, and it can overwhelm our existing defences. And that the threat of this is actually a kind of very primal, anxiety of annihilation, of disintegration, of loss of control, of health, of death of ourselves or our loved ones. So it really gets to the heart of our anxieties. And of course, we've seen defences at individual and population levels of splitting and projection. And of course, as with any other trauma, people who've had previous histories of trauma will suffer more greatly, even though there's this kind of talk of it being a shared experience. Actually, those who've got more difficult histories will suffer more. Next slide, please. SAMSA has kind of given us a definition for trauma, because I guess it's a term that we kind of can use without necessarily having a clear understanding of what it can mean. And essentially it's a kind of event or series of events that can be experienced by someone as emotionally harmful or life-threatening and has lasting effects. And perhaps it's the lasting effects that we really want to explore with you today. And increasingly we're recognising that the definition of trauma needs to be quite broad actually, and that we've probably been far too narrow in how we understood it, and that we should be kind of including racism, migration, and these sort of things, as well as the kind of more traditional ideas about adverse childhood experiences. Next slide, please. So when we think about what trauma actually looks like physiologically and what we see in our patients, It's really important to note that people who have been traumatized or are being re-traumatized are often moving between this kind of fight, flight, freeze cycle. And this has obviously implications for how they might be able to interact with us, but also in terms of their long-term health. And I suppose really importantly for us as psychiatrists going into medical wards is to actually pick up when someone is in a kind of flight stage or actually a fight stage, and to kind of think behind someone's anger and sometimes note that it could be a kind of traumatic reaction, as well as dissociation, which often really doesn't get picked up on. And obviously you can see that the kind of area where sort of healing can happen is in the kind of social engagement, in the green zone, where people can be calm enough to have curiosity about their own and others' mental states. So that's where we're kind of aiming for. Next slide, please. So what can trauma kind of look like? Because it's kind of the great masquerader, really. You know, we've talked about hypervigilance and dissociation and shame, but one of the things that often kind of can be underpinned by trauma, of course, is kind of coping and symptom control, so use of substances, drugs, alcohol, smoking, unhealthy eating, that sort of thing. But also in terms of how people interact with health services. So people who frequently attend A&E and services often have very high rates of trauma. But having said that, people who never attend health services also can have high rates of trauma. And that's because of kind of, you can imagine that if you've had traumatic events in your early life, turning up for screening that might be quite invasive is certainly not the first thing on your kind of to-do list. People might have kind of poorly managed chronic conditions, and we'll talk a bit more later about kind of the links between trauma and health conditions. And of course, in Ms. T's case, we can see refusals of treatment. Often what can lie behind a refusal of treatment is actually an attempt to kind of regain control over a situation and actually to put some boundaries in and protect someone from what is being felt as further harm. Next slide, please. And so we think about kind of, you know, why might healthcare in and of itself be re-traumatizing or traumatizing? So obviously the first thing that we might think of is kind of, you know, restraint and things like that happen in mental health settings, and we need to be very aware of those. But the kind of medical wards of a hospital can also be a very kind of powerless place for people who, if you've ever been a medical inpatient, you know that you kind of relinquish a certain amount of control over your privacy, over the time that things happen, over your body. There's kind of physical touch, there's quite invasive procedures. And if people have had early life experiences of neglectful or abusive caregivers, we kind of perhaps expect some trust that may not be really justifiable because they've had kind of authority figures that have let them down or have abused that trust. So why would they trust a hospital or a doctor? And of course, we need to acknowledge the previous discriminatory and re-traumatizing experiences that people have had. Next slide, please. So what can we do? Well, I think the COVID Trauma Response Group and also the Centre for Mental Health have given us some really helpful ideas, which builds on the ideas of psychological first aid, also closely aligned with Judith Herman's work, and really prioritises basic safety and kind of normal human needs as getting the kind of basics right. So that means making sure people have a safe place, somewhere that's quiet, somewhere where they have enough food, the right kind of interaction, so a kind of curious and listening approach from staff, but not intrusive and not expecting people to debrief about their experiences, and really protecting people from further harm or further re-traumatization. Next slide, please.
So there's a lot of food for thought here, and Miss T has been on your mind a lot. So you decided to bring her case to your psychiatry supervision group. And over the course of this discussion, a fair few number of questions emerged, which you discussed as a team. Next slide, please. So the first question that kind of came up for you guys is, what are the longer term physical and mental health consequences for people who recover from COVID? Now, we know that there's a link between inflammatory illnesses and depression. And if we think back to Spanish flu, and even more recently with SARS and MERS, we saw that to be the case. With regards to COVID, there's actually been a new study, hot off the press in the past couple of days actually, from Italy. And this was looking at a sample of just over 400 patients who were followed up a month after being discharged from hospital. These were all self-reported results, but they have so far confirmed what we suspected to be the case in terms of psychological sequelae. So just over a quarter developed PTSD, about a third depression, 42% anxiety, with a preponderance to females and those who have had psychiatric illnesses before. Overall, more than 50% had at least one psychiatric clinical syndrome. So it's really important that we do remain vigilant to this. And just remember, these patients are going home to a society that isn't normal. We're still in lockdown, social distancing, etc. So these can maintain depression. Next slide, please. So as well as a link between inflammatory illnesses and depression, we know there's actual considerable overlap with viral illnesses and fatigue. And chronic fatigue syndrome is a great example of that. There is the Body Politics COVID-19 survey, which was a really interesting survey rolled out on social media to capture the experiences of patients who were suffering from prolonged symptoms with COVID. It did allow for those who weren't tested, because we know that the availability across the country in terms of testing is quite varied. And so it did capture a good number of people. What was interesting was that pre-COVID, about 2/3 of the respondents said they were either very or moderately physically active. But at the time of the survey, after developing COVID, 2/3 reported that their lifestyle was now sedentary or mostly sedentary, and that was thought to be the fatigue that was behind this. And there is a lot of stigma still around fatigue, and there's difficulties adjusting back to real life, going back to work, etc. So that's important for us to have a think about when we think about supporting our patients. As well as the fatigue, there are other physical health consequences that people are still reporting. So things like low SATs, feeling out of breath, chest pain, tachycardia, to name a few. And with regards to cognitive disturbances, and we've heard a little bit before about this, we know that with COVID, about a third of patients had dysexecutive syndrome when they were assessed in one study. Next slide, please. So what do you think we can do in terms of trying to help Miss T? Well, we know that those who have a lot of physical health problems, and their recovery, their rehabilitation is often focused on the physical side of things, and the psychological side of things comes a bit secondary. But the COVID trauma response group do actually recommend screening, and you can do this using the intensive care psychological assessment tool, just a very quick bedside screening tool, or the iPad, which helps detect these things. ITU are quite good in terms of recognising that there is a post-ITU syndrome, but variability in terms of following patients up in terms of clinics, it does depend actually in terms of locality, but it really is just to focus on psychoeducation and supporting patients through their experiences. It's best that that's done by the psychologist in-house, but if not, there's always IAPT for when the patients are discharged. And if they do need a little bit more help, then you can go down the secondary services to get trauma-focused CBT and EMDR help for them. Next slide, please. And these are just a few resources that you can have a look at in your own time if you're thinking about where to signpost patients. They're peer support group services and are really good. Next slide, please.
So thinking again about kind of how trauma is relevant, many of you will be familiar with the ACEs study, and although it's from 1998, I think it's always worth mentioning, partly because, you know, it showed so elegantly and robustly that there is a dose-response relationship between adverse childhood experiences and later life physical health issues. And particularly of note were the kind of later life physical health issues that were thought to be kind of lifestyle diseases and diseases of kind of poor choice. And so really important that we've identified these links. And later studies, of course, have found links to a multitude of disorders, both mental and physical, and all of those that kind of overlap. But increasingly, there's there's work beyond ACEs to think about the kind of wider context of adverse childhood experiences, and indeed incorporating later life traumatic experiences, to think about mitigating factors and the circumstances surrounding people when these things happen to them, to include other adversities, so really to kind of broaden, as we've talked about before, broaden the understanding of what can be traumatic, and to really move beyond the kind of very European and kind of white perspectives on trauma, so to think much more about racism and the effect of that. Next slide. When we think about why trauma and adverse childhood experiences might affect poor health, the first thing that people think of is, of course, coping behaviours. So to think about kind of drinking, drugs, smoking, eating, and that sort of thing. However, it's really important to note that it's not just those things that contribute to people's increased risk of kind of diabetes, obesity, and other disorders. There is, of course, intersectional things going on with kind of other social determinants of health, poverty and employment and education and these kind of things. But there's also, at a kind of neurobiological level, really good evidence for the impact of trauma on the brain, on the developing brain, affecting neural connectivity, affecting cortisol, which we know is implicated in a huge range of mental and physical disorders, hyperglycemia, inflammation, and actually causing premature aging and shortened telomeres. And this has an intergenerational effect, both through direct effects, but also perhaps epigenetic effects that we're starting to see as well. Next slide, please.
So we wanted to have a think about racial trauma because, as Kate mentioned, we do need to think about this as a definition when we're thinking about trauma. So first of all, I guess, what is racial trauma? So this is a form of race-based stress, and it refers to people of colour and Indigenous individuals, their reactions to dangerous events and their experiences of racial discrimination. It can look quite similar to PTSD, but it's unique in the sense that it's not only their own individual experiences, but it's also collective experiences. So thinking about intergenerational experiences, their parents, their grandparents, but also centuries behind, slavery, colonisation. It can include threats of harm and injury, and it can also include thinking about what they have seen in terms of witnessing racial trauma in others. Now, Jones was particularly interested in looking at racial differential attainment from the lens of health outcomes and looking at why are there poorer health outcomes amongst different ethnicities. She developed a framework to understand racism on 3 levels. The first being institutionalised, and that means different access to services and goods in society based on race. So thinking about Miss T, did she have the same access to healthcare, education, employment compared to her white counterparts? The next level of racism is personally mediated, and these are personal discriminations and prejudices about an individual's motives, their abilities, and as a result, how do we actually react towards them? So again, thinking about Miss T, she came in with chest pain and shortness of breath, but this was all dismissed as being an anxiety attack. And then lastly, there's the internalised racism, and that's when the stigmatised individuals are resigned to accepting these negative messages about them. And that's really important because that is very likely to be feeding into why some people are not engaging with healthcare. So we can't just point the fingers at other specialties. We do need to have a look at our own in terms of mental health. What's happening with us? We are seeing high rates of Black male populations in particular who come into the mental health services via the police. They're more likely to be detained, more likely to be in forensic units, higher doses of antipsychotics, less likely to be referred to psychology. These are all uncomfortable truths, but they are truths nevertheless. And we do need to acknowledge them in order to have discussions how to improve engagement and outcomes of these already marginalised populations. Next slide, please. Just a few further examples in healthcare settings, not just in mental health, but things that we do need to be aware of. Things like, the acute management of MIs, analgesics, the treatment of PTSD, And this one in particular I found quite shocking, being in a developed Western country, but Black women are 5 times more likely to die in a year after childbirth. Asian women twice more likely, and that's regardless of socioeconomic statuses. So these are really shocking things, and we do need to pay attention to it. Next slide, please. It couldn't have escaped your knowledge, probably, that there's been a lot of discussions around the disproportionate deaths seen amongst BAME communities with regards to COVID. And we know that Black populations are 1.48 risk and Southeast Asians 1.44 risk of dying compared to their white counterparts. And that's even when confounding factors are adjusted for. Public Health England did issue a report. The first didn't quite reflect the roundtable discussions with BAME organisations. So they have issued a second report called Beyond the Data. And this was looking at, why are we actually seeing this disproportionate amount of deaths? They acknowledge that institutional racism may well have played a part. People, less likely to seek healthcare provision, and healthcare professions less likely to speak up about a lack of PPE. We also know that BAME groups are more likely to have health problems such as high blood pressure, obesity, lung conditions. They're more likely to be in the front row occupations such as bus drivers, supermarket workers, and thus increasing the risk of contracting the virus. In short, the pandemic exposed what we already knew, and that is there are long-standing, not only health, but socioeconomic inequalities still in our country. Next slide, please.
So this is a little bit unwieldy, but this is a kind of attempt to bring together how all of these things have affected Ms. T and kind of intersected to affect her health outcomes. And we heard that she certainly experienced kind of medical racism. She had an experience of diagnostic overshadowing, where her concerns were dismissed. And we do see this very commonly with women, and particularly with Black and minority ethnic women. That will of course affect her, how confident she will feel in seeking help in the future. And when we think about the things that might kind of underlie her risk factors for severe COVID or even contracting COVID, and also severe risk factors for developing PTSD after COVID. So she's got these underlying health conditions which are potentially related to adverse childhood experiences, and certainly those are risk factors. So she's at higher risk of having a severe COVID. She's then also at higher risk of having a delirium and ending up in ITU. And when she's in ITU, that can increase her risk of having PTSD. Her prior history of trauma increases her risk of having PTSD after that ITU experience. And when she leaves hospital, she's facing the kind of stigma of having had COVID, perhaps having chronic kind of COVID-related symptoms. She emerges to a society that is talking about, sorting out obesity and tackling obesity. So she's internalizing these ideas that that's her fault and that she should have done more. There might be pressure to return to work. There's an unstable financial and economic situation. There's a question of whether or not she can access culturally sensitive diagnostic processes and therapies, whether she'll find a therapist that she can feel comfortable to really be open with, and whether services are equipped to make her feel safe. And then of course there's the kind of secondary and collective trauma related to the kind of loss of life from people from her community, from BME communities, and also the kind of collective trauma of George Floyd, all coming together in this very short amount of time. Next slide, please. So what can we actually do? Well, I think hopefully we've given you some ideas already in terms of interpersonally and kind of what we can do as even very junior doctors in a liaison setting. But thinking perhaps more broadly now, trauma-informed care does give us a framework for thinking about how to kind of respond to trauma. But really importantly, we need to understand the critical roles of all of the intersectionalities and different types of trauma at play. And Angela Sweeney describes this very well in her paper, looking at trauma-informed mental health care. Next slide, please. So really, the SAMSA guide kind of gives us a good framework for thinking about this. And this again operates on both an interpersonal level and at a system level if we think about how we should be structuring our services. So it is about acknowledging how common trauma is and setting up our services and our interactions accordingly, recognizing what trauma might look like and how it might present, and not dismissing things, and really kind of digging a little bit deeper to think about what might be going on. That doesn't necessarily mean asking people about their trauma at every single opportunity, but it's more about a stance and us keeping that in mind. The other thing is that if we don't acknowledge that racism is a trauma, we will fail in the way that we kind of construct our services. And it's about integrating this knowledge into all of our policies, procedures and practices, and having staff who are supported enough to be able to engage in the trauma that they're going to be seeing. And of course, we're actively trying to resist retraumatization. Next slide, please. So what does this actually look like? Well, once again, kind of Judith Herman gives us a really clear kind of imperative for how we should support people. It's about empowering people who've survived trauma. It's not about doing to them, it's about giving control back. Because of course, actually one of the core experiences of trauma is not having control. So it is all about giving control back. And that's both in how we interact with people interpersonally, but also how we kind of develop services. So that means kind of involving people, co-production at every level, and like genuine collaboration. It's about making safe spaces and giving people choice wherever we possibly can, and putting them back in charge again. So in Miss T's case, that was kind of asking her what could be helpful at this point, and thinking about what does she think needs to be in place before she leaves hospital to keep herself safe. It's about being trustworthy, so giving clear expectations about what we're going to try and do, and being honest when we're not able to do things. Next slide, please.
Okay, it's now 2 weeks later since our encounter with Miss T. She's discharged home now with twice daily package of care, and she's getting ongoing rehabilitation with the community pulmonary rehab team and some interim psychology support from them. There is a plan that she will be referred to IAPT for longer term psychological intervention. Miss T is still on sick leave, but there's a plan for a graded return to work. She's back in touch with her friends and has joined the local support group. So overall, she's a little bit more hopeful about her future and is a little bit back to her old self again. Next slide, please.
All right, so that brings us to the end of Miss T's story, and quite an optimistic ending with quite a lot of positive hope about the future. We just wanted to draw together some of the key learning points that we hoped you would take away from this. Firstly, just that there are multiple neuropsychiatric sequelae after ITU admission, and we've got reasons to suspect that morbidity will be high after COVID-19, and the initial studies that are being published are certainly suggesting that that's the case. We also wanted to highlight that trauma, both in early life and in adult years, can have a huge impact on someone's health and on their ability to receive medical care. And that's something that as professionals, we have to be very, very mindful of. We also wanted to highlight the structural and interpersonal discrimination that affects people from BAME backgrounds in terms of their risk of COVID and their outcomes when recovering from COVID. Medical care itself can be traumatizing, particularly in the context of critical illness and delirium. And some of the supports which might have minimised this are much less available now that we're in a pandemic situation. And finally, if you take nothing else away from this presentation, please take away that trauma-informed care can offer us principles for supporting survivors of trauma as we go through our practice.
So as Dr. Evans had already said, a huge number of people were involved in this case. We're very lucky to have very generous people participation and a number of MDT specialists who've assisted us both with this case and an earlier version of the case, and also the just ELFT medical education have been very supportive along the way as well. Next slide, please. And these are a kind of collection of resources. We'll definitely be sharing the slides. Thank you very much for the requests for that. And these are a kind of collection of resources that have kind of informed our thinking about this, including suggestions from some of our people participation reviewers as well. And we'll go to the next slide and take some questions if there's any time left.
Lovely. Thank you so much, colleagues, for what was a really powerful and quite emotional, moving presentation. And I also want to thank all the participants for the absolutely wonderful, rich discussion in the chat. I don't know if there is some way of capturing that discussion to go back and revisit, because there's some really wonderful dialogue going on there, debate, and a particular quote. May I please repeat it? At 4:53 p.m. "The sorrow which has no vent in tears may make other organs weep." So, a couple of responses to your questions. The slides will be available through the college, so that's the first thing. The second, I want to take a question that's come up. We have an aspiring medical student who is interested in psychiatry and wants to know how. I'm just going to say, I think probably, hopefully, the college will help you. So get in touch with the college to do that. I'm going to pick a couple of questions. There's some fantastic questions here, but I'm going to look at two which have caught my eye. One is about terminology, and it came from Bethany Cole, wanting to check about terminology, that we refer in the talk to traumas. So I'll read it. "Your talk refers to her experiences as traumas, though ICD-10 does refer to stressors, including illness under adjustment disorder. Do we look at severity of the illness when differentiating between stressor and trauma, or should we use the impact on the patient to differentiate?" I think that's quite an... Can anyone pick that up? Or we can leave it out there for discussion. The panel?
I guess I'm happy to say, I mean, I do think language is really important, but I suppose I would tend to be more at this point, particularly in this case, looking at kind of formulating more than kind of diagnostic categories. Maybe that's kind of taking the easy way out, but I think in the middle of the night, I'd be thinking more about what's important to this person in this situation right now. And then in the kind of cold light of day, maybe I'd go back and be looking up the kind of ICD criteria and kind of thinking about what next. But I guess, yeah, that's kind of where I would sit. But and particularly use the person's own words if at all possible.
Thank you, Kate. Thank you. Now, there is another question which I was interested in, which was about what if someone had learning disability, and what is our experience, or what is your experience of this scenario with people who have learning disabilities? Any insights?
I don't mind going again, but unless anyone else wants to jump in. I mean, I suppose one of the cases that we did within ELFT was looking at someone with LD on a medical ward, particularly because we were quite concerned. It was at the time that the clinical frailty score was perhaps being applied incorrectly. So we really wanted to kind of highlight the role of liaison psychiatry in advocating for people with LD and severe mental illness in receiving good medical care on medical wards. I think I'm not an LD expert, but I suppose, you know, one of the things that I think as general psychiatrists we're probably not necessarily that good at is picking up trauma in people who have LD, and there are probably very, very high rates of trauma in that population as well. You know, behaviour that might seem to us to not make sense may well, in the same way that we've described here with people who don't have LD, you know, we may dismiss it as kind of behavioural and that sort of thing, when actually trauma might underlie it. So I think it's all about communication and kind of the communication difficulties that very, very commonly happen on medical wards.
Thank you, Kate. I think we've come to the end of our time and there are lots more questions, but if I may just leave our participants with 3 questions for us to ponder as we go away. We wondered about, should we be screening for PTSD post-ITU for COVID? How many psychiatrists ask about experiences of racism and experiences of trauma related to healthcare? And what can healthcare organizations do to be more trauma-informed and more anti-racist? thank you very much for spending time with us. I hope that you found this session useful. Thanks very much and goodbye.